Good morning, everyone, and thank you for joining us bright and early this morning for our Wake Up with Research breakfast. So I'm Daryl DeWald. I'm Vice President of Health Sciences for WSU, and I'm Chancellor of the WSU Health Sciences Spokane campus. This is our second breakfast in this series. Last month, we heard from Dr. Celestina Barbosa-Leiker and Dr. John Roll about the broad overview of the COVID-related research that's happening across our WSU system. As well, we heard about the pandemic and how it's affecting women and women during pregnancy. Today, we're going to continue to explore our research and how it relates to COVID-19 effects, especially as it relates to our vulnerable populations. Our goal with these breakfasts is to provide you a backdrop for you to learn more about the research that is happening in our community, but right here in Spokane. In addition, it gives you an opportunity to put a face to a name for these incredible researchers, these people who are committed to your betterment, these people who spend their life and their career discovering and then applying their discoveries. Our researchers are making important contributions not only in the fields of COVID-19, but in sleep and performance, with addiction, autism, cancer, aging, chronic disease, community health, neuroscience. Well, the list just goes on. So for us, it's exciting to share our researchers, our scientific leaders with you in this type of a forum. These dedicated, amazing people are discovering and working through some very complex and life-changing problems that will ultimately enrich the quality of life for all of us. I now want to acknowledge our incredible sponsor, STCU. And there is no one better to represent STCU this morning than our very own WSU Regent, WSU alumni, and Spokane native, Marty Dickinson.
Well, good morning. Thank you, Daryl. I appreciate the introduction. And I really just appreciate, and so does STCU, this opportunity to sponsor our Wake Up with Research series. It's really something that, as both a regent of Washington State University, somebody that was a student and a graduate from WSU, and as a professional in our community, we are just so grateful for the people that are on this call today, the people that you're going to hear from, and the work that WSU does around research and how that serves our communities and the populations that we all are dedicated in serving. One of STCU's really core values is education. And I think that, it's fair to say that WSU and STCU have had a very long-standing partnership, in particular in Spokane. WSU Spokane and STCU early on came together around the College of Nursing, and it's something we've been involved in for over 2 decades. We had the opportunity to be an entry partner on this vision that is now such an amazing reality called a medical school. And we have been involved in sponsoring pharmacy programs, and it's an honor. Many of you, and so many of who we are going to hear from today, as well as in the series that Daryl referred to, that they're part of our community, and you're part of our community, and you're making it better for those that live here. And the economic drivers and the other things that come with all the work that so many of you are doing, it's hard to kind of put that into words, and sometimes it's hard to even measure. So these kinds of forums are really, really important. And so I just would say thank you so much. We are glad to be doing this with you. And again, as a WSU Regent, I'm just so proud and honored to be able to represent all of you and to champion and advocate on your behalf. So thank you so much.
Thank you, Marty. We are very grateful for your support, and we're glad you're joining us today. I would also say thank you for your leadership for Spokane. Now I'm going to hand things over to our Vice Chancellor of Research at WSU Health Sciences, Dr. Celestina Barbosa-Leiker. Celestina is not only our Vice Chancellor of Research, but also and associate professor in the College of Nursing. She's an elected member of the Washington State Academy of Sciences, a member of numerous professional associations, including the American Psychological Association, and she has touched on some of her research at our first breakfast. And this research has led to nearly 100 publications. We're proud of her, but we also know that she represents this great cohort of strong researchers. So Celestina, over to you.
Thanks so much, Daryl. Good morning, everyone. Thanks for waking up with the research bright and early with us again. Our second breakfast now. Our last breakfast covered broad and general research related to COVID-19 across the WSU system. And today we get to continue that interest in COVID-19. We know it's on everyone's mind, and we have some great speakers here to share their research related to COVID-19 and vulnerable or at-risk populations. My hope is that you'll leave here today with an even better understanding of COVID-19 research, not just across the entire WSU system, but also here locally as it relates to research going on in Spokane and research efforts here in Eastern Washington. But before I introduce our speakers today, I want to touch on what got us here as a university. So WSU is a land grant mission. And what that means is that the mission of our university is to serve the entire state of Washington and all of the residents in our state. And in part, in doing so, in achieving our mission, we're able to do that in part with at the WSU Extension offices that are in every single county across the state of Washington. For the WSU Health Sciences Spokane campus, what our land grant mission means to us is that we are here to serve every resident in the state of Washington in order to help improve and better their health and well-being across the entire state and beyond. And not only through education of our nurses, pharmacists, and physicians with a heavy focus here in the state of Washington and in Eastern Washington, but also through our research. We're also here to help improve the lives of every resident in the state of Washington through our research. And so that's a perfect transition into our speakers today, because that's exactly what they're doing. So let me start with introducing our first speaker. So our first speaker this morning is Dr. Kaimi Sinclair. Kaimi is an associate professor in the College of Nursing here at WSU and the Associate Director of Partnership for Native Health at Washington State University. As a researcher, she works with underserved communities to reduce cardiometabolic disparities. For more than 2 decades, Kaimi has developed, implemented, and evaluated culturally adapted interventions to promote health and prevent disease in several health disparity populations, including American Indians, African Americans, and Latinos in Detroit, and Native Hawaiians and Pacific Islanders in Hawaii and Washington. Today, Kaimi is going to talk about COVID-19 research as it relates to an at-risk population here in Washington. So Kaimi, welcome.
Thank you, Celestina. Thank you so much for the invitation to talk with you at Wake Up with Research today. Well, within the US, we've seen the pandemic impact racial and ethnic groups differently, disproportionately affecting communities of color. Many of the inequities that existed pre-pandemic put communities of color at risk during the pandemic. So for example, social distancing is actually a privilege that many people of color aren't able to adhere to because they're a majority of our essential workers. And most of these jobs require the physical presence of workers. So even if these workers could stay home, they may be more likely to live in cities and in multi-generational and multi-family households, which makes it even harder to social distance. So the Pacific Islander community, particularly the Marshallese, have been hit hard by the COVID-19 pandemic. For example, in June 2020, the Spokesman Review reported that the Marshallese people represent 1% of Spokane County's population, but almost 30% of its COVID-19 cases. Similarly, in Northwest Arkansas, where the largest Marshallese population lives, the Marshallese community represents less than 1% of the population, but they accounted for more than 1 out of 5 COVID cases in that area. Well, through a grant we recently received from the National Institutes of Health called Marshallese Alternate Surveillance for COVID-19 and a Unique Population, Mask Up is the acronym, we're partnering with the University of Arkansas Medical Sciences Center for Pacific Islander Health to use innovative, culturally engaged, participatory surveillance methods to identify and evaluate strategies to reduce the spread of COVID-19. So participatory disease surveillance complements traditional surveillance methods that you may see the departments of health use by engaging communities in reporting COVID-19 symptoms and events. So the Mask Up study is going to recruit Marshallese community members in Washington and Arkansas during the next 3 years to participate in the 12-month study. Marshallese community health workers will be hired to recruit participants who will then be asked to report symptoms of COVID-19, such as an increased temperature, a loss of smell and taste, and when they've been in close contact with another person with COVID-19, and if they've been diagnosed with COVID-19. And all this information in research is kept confidential. So the study will use social media and text message-based screening technology to augment these conventional test-based surveillance. And Mask Up, we hope, will demonstrate the value of a culturally engaged participatory disease surveillance developed and tested in real-world settings to mitigate COVID-19 disparities in this high-risk clustered population that's been profoundly underserved by public health efforts to date. So our findings will be able to be adapted and disseminated for improved surveillance and disease prevention in other high-risk, non-institutionalized U.S. minority groups too. So we're really excited to get going with this study in the next few months. Thank you, Celestina.
Great. Thanks so much, Kaimi. Thank you for sharing that research study that you're working on now. We have pre-submitted questions already, for you, but I encourage everyone watching this morning to go ahead and send questions our way with the chat function that you have there. So when we have a Q&A session at the end, all of the speakers can go ahead and answer all of your questions live here. So thank you, Kaimi. Next up, we have Dr. Pablo Monsivais. Pablo is an associate professor in the Department of Nutrition and Exercise Physiology here at Washington State University. His research is on social and behavioral epidemiology of food consumption and obesity, and it's aimed at identifying population-level drivers of social inequalities in diet and health. This morning, Pablo is going to share some COVID-19 related research as it relates to vulnerable population. So welcome, Pablo.
Thank you for having me, Celestina. And good morning to all of you. I'm happy to share with you some of my recent work at this Wake Up with Research. Like so many others in health sciences, my own research wasn't originally focused on coronaviruses or even infectious diseases of any type. My work in the Department of Nutrition and Exercise Physiology has historically focused on understanding the causes of what I call our pre-existing pandemics: heart disease, cancer, metabolic diseases like type 2 diabetes. These are actually the leading killers and causes of disability. And they're mostly preventable through healthy diet, regular physical activity, not smoking, and maintaining a healthy weight. But these diseases also show some strong social inequities. For example, heart disease and diabetes are much more common in people of color than in whites. And similar trends exist for people living in poverty and in some rural areas. So my research has historically looked at why this is and how differences in diet and activity play a part, making some communities more vulnerable to obesity and chronic diseases. So when COVID came along, my WSU colleague, Dr. Ofer Amram, and I soon realized that the pattern that was showing up in the coronavirus pandemic looked a lot like the patterns we'd already seen with obesity, diabetes, and heart disease. In fact, Within a few weeks of the pandemic beginning, local public health agencies around the country and the CDC started seeing this pattern too. People living with obesity or diabetes were much more likely to suffer severe complications from infection and more likely to require hospitalization and die as a result. As the cases mounted, we started seeing another pattern where it looked like outbreaks and higher infection rates were happening in poor areas, communities of color, and areas where people worked in jobs with higher risk of exposure to the virus. Think of occupations like food processing, retailing, transportation, and other frontline work. So we developed an index that took these community characteristics into account. In a way that we could use to predict areas that would face higher risk of COVID transmission. We published a study describing our index for Washington State. It was one of the first studies showing how vulnerability to COVID varies across communities for an entire US state. We also created an interactive tool for people to explore and interact with the data. We do this actually with some of our research as a way to make the science we do more accessible and hopefully useful to non-scientists. But we're especially interested in people using the data and using it for to promote community health equity, both in Spokane County where we are, as well as across the state. Okay, so now I want to tell you about a more recent and ongoing project that Ofer and I designed in partnership with MultiCare of Washington to look at another type of health inequity resulting from the pandemic. This has to do with cancer and cancer prevention services. So you might know that breast cancer is actually one of the leading types of cancer that occurs in the United States. However, it's actually got pretty good survival rates, in part because of the routine breast screening that many women have access to. But in the pandemic, because of closures and lockdowns, many health services, including cancer prevention services, were canceled or postponed. Early research in the UK was indicating that many cancers were going undiagnosed because of the loss of screening services during the pandemic. So we worked with MultiCare to look at this in Washington State, and were funded by a grant from the Andy Hill Foundation of Washington. This slide here shows you some of those initial results that we've obtained from the study of MultiCare patients between 2018 and 2020. And what I want to draw your attention to on the left side of this graph in black is showing the big drop between 2019 and 2020. These are just breast cancer screenings among women. And you can see a big gap between 2019 and 2020. That's about a 50% decline in cancer prevention screenings. And we attribute that to a lot of these COVID-related shutdowns of services, but also just precautions that people were taking in avoiding exposures to themselves and their families. So the 50% drop we saw overall was not really surprising. It's consistent with what others have seen. But what we were able to do is dig a little deeper and look at how different population groups were affected by this drop. So on the right side of this graph, you see that not all, these are just looking at racial ethnic groups of MultiCare patients. And what you can see is that not all groups showed the same amount of decline in screening. So for example, non-Hispanic white women overall showed a decline in screening of about 49%. Not good. But if you look further to the right, you see that American Indian, Alaska Native patients and Hispanic patients showed between a 61 and 64% drop in screening. So that's a big extra decline that those population groups showed. And to us, that's a worrying sign. We see similar trends for women in rural areas and those who were either self-pay, meaning they were uninsured, or women who were insured by Medicaid, those women also showed large drops compared to women who were in urban areas and women who were privately insured. Overall, these results tell us that although there's a clear effect of the pandemic on reducing prevention services, some groups in our society are hit much worse. Apart from breast cancer, we're also looking at other cancer types for similar inequities. So the goal here is to see how our health services can better maintain services and care in the face of this and future disruptions. So these projects are just some of the work I do that overall is aimed at identifying how we can make policies and environments more supportive to healthy living and promote health overall, but especially among populations and in communities that face excessive rates of disease. So I'll leave it there. And again, thank you. And back to you, Celestina.
Thank you so much, Pablo, for sharing your research. Oh, it's so fascinating. I know so many of us were trying to be extra careful and maybe not doing the preventative appointments that we normally are on top of, just only wanting to head out and if absolutely necessary. So thank you so much for that, for sharing your work. Our final speaker today is Dr. Kim McKeirnan. And Kim is an associate professor in the Department of Pharmacotherapy at WSU's College of Pharmacy and Pharmaceutical Sciences. She graduated with her Doctor of Pharmacy degree from WSU in 2008. We have a couple of alumni here on this panel, and joined the faculty at WSU in 2013 after 5 years in community pharmacy practice. She's the director of the Center for Pharmacy Practice Research at WSU and is passionate about research involving community pharmacy, public health, and improving patient access to care services. Kim has received grants for improving immunization rates in rural areas, developing a model for implementing chronic disease management services in rural community pharmacies, and developing a pharmacy technician immunization training program. She's recently a recipient of several regional and national awards for teaching and research, including the 2019 American Pharmacist Association's Immunization Champion Award. Thanks for joining us this morning, Kim.
Great, thank you, Celestina, and thank you all for having me here today and for the opportunity to share some information about my research with all of you. So I am, as Celestina said, first and foremost, a pharmacist. I worked in community pharmacy practice prior to joining the faculty at WSU in 2013. So as a pharmacist, I certainly saw many wonderful things that we're doing with patient care, but also some opportunities for improvement. And so my research, since I've become a faculty member, has been centered around how can we improve the practice of pharmacy, both for pharmacists as a working experience, but more importantly for the patients that we serve. So I'm excited to share. I have 2 different projects that I wanted to share with you today. I think we have slides for these. Great. So the first one I wanted to talk about with you is training pharmacists, students, and technicians to administer immunizations. So pharmacists, as you may or may not know, immunize. We have 50 different states with 50 different pharmacy practice acts. So the rules vary state to state. But in the state of Washington, pharmacists can administer immunizations to anyone down to the age of 6 months with any vaccine, as long as it is prescribed through a collaborative drug therapy agreement. So in a pharmacy, if you've ever gone into one to get immunized, you may notice that sometimes there is a wait involved in this. In a pharmacy, you have a pharmacist who has typically a doctorate degree and is doing a lot of complex tasks. And you have many pharmacy technicians who have a degree that's either equivalent of community college or sometimes it is on-the-job training. So as we look at pharmacists taking on new clinical roles and wanting to provide really high quality patient care, we start looking at, we have these amazing pharmacy technicians, but they're not always utilized to the extent that they could be. So starting in 2016, I partnered with the executive director of actually the Idaho Board of Pharmacy and created an immunization training program specifically for pharmacy technicians. Because my rationale with this was that if we can engage technicians in tasks that don't necessarily require in-depth clinical judgment, we can ease some of the work burden on the pharmacists so they are opened up to do more clinical patient care tasks, and we can also shorten patient wait times. We see that becoming extremely important with COVID-19. So right now, when the vaccine, has come out in these last couple of months, we hear stories on the news of people waiting in their car overnight in line just to get vaccinated. Older adults that really would be better off at home being safe in their own space than sitting in a car overnight. So as we see more and more people immunized, we're going to see the bulk of people who really want to be immunized are going to get immunized in the next several months. But so as this happens, we also know that there's a sector of the population that's not really interested in getting immunized, right? You've all probably heard this on the news before, that it's somewhere between a half and a third of the US population, depending on what source you look at, isn't really interested in getting a COVID-19 vaccine. So knowing that we need somewhere between 70 and 90% of our population exposed to COVID-19, and whether that is through natural exposure or vaccination, either way, but to achieve herd immunity, we need this to happen. So we're really encouraging everyone to get immunized with this vaccine. So where do pharmacy technicians and pharmacists come into this? Well, we can play a big role in this as vaccine is rolled out through pharmacies, in part by making this convenient. If there's a patient who is really on the fence about should I get immunized or not, data shows that a strong recommendation from a trusted healthcare provider is one of the most effective ways to encourage someone to get immunized. It really works for the most part when you have someone you trust tell you they think you should be immunized. So if we have pharmacists giving that strong recommendation and strong rationale, scientific information on why this is important, and then we make it really convenient. You can walk into a pharmacy in a grocery store or an independent pharmacy, Walgreens, and be immunized. And the more convenient we can make that, as in short wait times, the more uptake we imagine we can have with this. So I think it's going to be a really important piece as COVID-19 vaccine becomes more widely available in encouraging a large percentage of our population to get immunized. So more to come on that as the next year progresses. Another piece with that I think is extremely important as a role that pharmacists can play is in immunizing children. So as Dr. Monsivais and Dr. Sinclair were just talking about, there are huge health disparities that we knew previous to this COVID-19 time with minority populations and populations of color, things we were trying to address prior to this, but have been exacerbated during COVID-19. So there again, creating access is a huge role for pharmacists. We see this has also been the case with pediatric immunizations. So as Dr. Monsivais was saying, breast cancer screenings have gone down. We've seen routine pediatric immunizations for children across the country and outside the United States as well have also gone down. And there are kind of two reasons for that. So one, when COVID started, you may remember that many healthcare providers were told, do not provide healthcare that is non-emergent during the March and April time window, simply to avoid the spread of COVID-19 because it was all still so new. So healthcare providers are being told, if it's not emergent, don't do it right now. And people are being told, stay in your home. If it's not emergent, don't go outside. So while these things were really important in stemming the tide of COVID-19, they also led to many children who should have been immunized in the last year not getting immunizations. So pharmacists now in all 50 states, as a result of an emergency preparedness amendment from the federal government, pharmacists can now administer all pediatric immunizations that are routine to kids across the country. So I think we have a huge opportunity to address those inequities that we saw before by reaching minority populations of color. So I think there's huge roles for pharmacists with that. The second topic that I wanted to share with you is some work that I've been doing a bit closer to home. I grew up in Pomeroy, Washington, which, as some of you know, is a very small town, smaller than Pullman, actually, a little bit south of Pullman in the state of Washington. So my other project has been looking at increasing pneumococcal immunization rates in rural areas. I was fortunate enough to receive a grant from Pfizer's Independent Grants for Learning and Change. So this is their foundation that offers funding to scientists who are interested in working in kind of the areas of immunization, although not specifically related to a vaccine that they're selling, really more immunizations in general. So we decided to take, we were looking at this problem, how do we increase immunization rates. So pneumococcal vaccines specifically for adults ages 65 and over. How can we bump up those rates? Because you can see, pneumococcal disease is such an issue for older adults when perhaps they get the flu or some other issue that can be irritating to their lungs, and it results in, life-threatening and life-changing problems due to pneumonia. So what can we do about that? So we decided to take an academic detailing approach. And academic detailing is a concept that was developed at Harvard Medical School by a couple of physicians who work there, who I had the chance to meet a few years ago when I went there for some training. So academic detailing is this concept that as a healthcare provider, I can train other healthcare providers using evidence-based guidelines. So it's kind of like taking the concepts that drug reps use to try to sell you things, except that I'm not trying to sell anything. I'm just trying to get you to use the evidence-based guidelines. So we met with a number of physicians, nurse practitioners, and other healthcare providers in a couple of rural counties outside of Spokane, and just provided some updates. We had students, medical students, pharmacy students, and nursing students who gave some very nice PowerPoint presentations that they wrote during lunch and learn sessions or during staff meetings, just to get everybody in those clinics up to date on why pneumococcal vaccine is important and some things that could be done. We also shadowed their staff as they went about their day to see where would be some opportunities for the medical staff to maybe better identify folks who need pneumococcal vaccine, which is really nearly all adults ages 65 and over. So we found that with minor tweaks to the electronic health system, some additional awareness among the staff, and we also made a nice exam room poster that they asked for, that we posted up in all of the patient waiting rooms. And we found that this did make a statistically significant increase in the number of patients who were receiving the pneumococcal vaccines. There's both pneumococcal vaccines. So those are some of the pieces that I've done so far. I'd love to answer questions if anyone has them, and I will turn it back over to Dr. Barbosa-Leger.
Thank you so much, Kim. I cannot think of a more timely topic than the COVID-19 vaccine and reducing wait times to get the vaccine. All of that, I hadn't thought about the fact that if someone's on the fence, these long wait times or even just the difficulty in trying to get scheduled for the vaccine would be an added barrier that might make them just say, you know what, I'm not going to do it right now. So thank you so much for highlighting that and all of the other work that you shared with us. So now we get to do the question and answer portion. We've had questions coming in. Thank you so much for those of you that have put questions in the chat. For those of you that haven't yet, now's your time. Go ahead and put some questions there. In the chat, we have our experts here and they're happy to answer any questions. So I'm going to start with one actually for all three of the panelists. A common theme that we heard this morning from the three of you was that the health disparities that we see didn't start with the COVID-19 pandemic. They were going on before the pandemic, and it seems like the COVID-19 pandemic has really exacerbated or made worse these health inequities. Was this something that you all were anticipating and expecting at the start of the pandemic? Was it a surprise to you? What were your thoughts around that? And is it making just everything worse or just a few things worse for some of our vulnerable populations and at-risk groups? Who wants to start?
I'd be glad to jump in. So I think that, in times of challenge, we see things that were already an issue just flare up and be made worse by these additional barriers that have come in. I know quite a bit of the work that I've done, as I mentioned, is with rural and underserved populations, but we certainly see this with urban underserved populations as well. But definitely made worse by the additional challenges related to COVID. And I think this is something that many of our faculty at WSU are working to address, albeit in different ways, different methods, but certainly working on increasing access. To me, that's the biggest piece, is access to care. Because if people are worried that they're going to have to pay a substantial amount of money because they don't have insurance, access to a car is another big one, at least with immunizations. That's been shown to be a barrier. I'm sure that's the truth with healthcare in general. So I think if we can address even some of these basic issues, it's going to go a long way toward fixing this issue.
Great. Thanks so much, Pablo.
Yeah, if I may build on that, I got my thoughts flowing there, and I think I have to step back and really, when you look at what are the drivers of population health, all of the research seems to point to the fact that about at least half of public health, the state of public health, can be traced back to socioeconomic conditions. Meaning it's not about healthcare, it's not about genetics, it's about the fact that the places we live and the resources we have access to determine our health outcomes. So when you look at things like chronic diseases like heart disease, or in the case of COVID-19, you see a lot of the same patterns because, as Dr. Sinclair pointed out, many of those communities don't have the luxury to protect themselves in ways that we've been advised to. Staying at home, working from home. I have the luxury to work in my comfortable home here. That's a luxury, and not everybody can do that. So I think that we're seeing this pattern basically repeat itself, and that just is a sign to me that we need to really go upstream and address those social determinants of health.
Great, thank you. Kaimi, what about in our local Marshallese population? We had a comment come in saying, my goodness, 1% of our population, but 30% of folks with COVID-19. What are your thoughts on that?
Well, I hope that through this research and other research that we're doing in the Pacific Islander community, that some of the things that might come out of this is that people will realize the large Pacific Islander community that we have in Washington. So we do have the third largest population of Native Hawaiians and Pacific Islanders outside of Hawaii and California. So we have this large group that's really remained pretty invisible to people. And your first question about, did we realize that this would happen with COVID-19, the impact, and I think we did. We didn't, really realize everything about COVID-19 early on, but I think that we could foresee the impact, the disproportionate impact on communities of color because of the work, the health and equity work that we did before COVID. And, nothing changed from pre-COVID to post-COVID. It's socioeconomic status, in, other disparities that communities of color experience. So, I'm hoping, and I think that, the publicity, the news, the research devoted to addressing disparities in COVID-19 will raise awareness around the country about, disproportionate impact of many disparities on these communities of color that really did, were invisible beforehand. So we hear, a lot about the African-American community and Hispanic community, rightly so. They are, impacted as much as the other communities of color, but people don't really know or pay much attention to the population of Native Hawaiians and Pacific Islanders we have here in Washington and in other states. I mean, nobody probably knows about the Marshallese in Arkansas, in Northwest Arkansas, who are the large population of workers in the chicken processing plants that are located there, and other meat processing plants. So
great. Thank you so much. We're getting a lot of comments from our viewers this morning, just sharing their appreciation with all of the work that the three of you are doing to highlighting health disparities and the work in the communities that you're working with. The next question that I have, and it pertains to the three of you. As we wait for vaccines in our community to establish its herd immunity, what is the fate of your research, especially when human subjects are involved? Kim, maybe you can start us off with a quick definition in case any viewer doesn't know. What is herd immunity? And then how does that impact your research?
Absolutely. I will say with research, it has been a challenging year to be conducting research with human subjects. But what is herd immunity? So it's also known as population immunity. And this is the concept that an entire population can be well protected from a disease, a vaccine preventable disease, if enough of the population is exposed to protect those that either have not been exposed or really cannot be exposed. What I mean by that is, so people exposure, so it can be natural exposure, so you get COVID-19 and recover and now you have antibodies and some immunity to it, or it can be through vaccination, either one. But the rates differ from disease to disease. So the measles rate and the polio rate are going to be different than the percent of the population we need to have with this exposure, hopefully through vaccination and not, infection, but to protect those vulnerable populations. Basically, we know there are adults out there who are immunocompromised, who there's concerns with getting a vaccine, or getting COVID itself could be quite catastrophic for them. So in order to protect them, the rest of us need to get immunized, is basically the short version of that. So how has this impacted my research? Oh gosh, it seems like most of the work that I do is with human subject populations. So whether I'm studying, reaching out to other healthcare providers to study how they run their practices, or patients to see what their experiences were like interacting with providers in different settings, working directly, I do patient home visits with underserved populations in some very rural areas north of Spokane. And all of that was kind of shut down when COVID-19 hit. I know our research folks here at WSU wanted to be extremely careful to make sure that we weren't, unknowingly exposing our scientists or anyone else, any of the patients or anyone else that we're interacting with. So it's been a big challenge this year. I will say I'm part of a national study that was looking at pharmacies doing point of care influenza testing. So the concept behind this is that if you think you might have the flu, you could go to a pharmacy. They would do a nasal swab and run a quick test and say, yes, you have the flu and here's your medication, or no, you don't have the flu and let's figure out, what the next step is. Well, that was all well and good until COVID hit, and then anyone with any kind of respiratory symptom who showed up in a pharmacy would not be tested for influenza. They would be immediately referred to go get a COVID test. So that study, completely derailed. So that's been disappointing. But at the same time, I think there's so much opportunity for us to learn and grow from what's going on right now. And one, prepare ourselves in the case that, of a future pandemic, but also look at, as we've been talking about with my colleagues, the challenges with inequity in healthcare in general that have just been made more evident really by what's going on. This is a great wake-up call to all of us to address those problems.
Great. Thanks so much, Kim. Amy, what about you and your research? How has this impacted your research?
So, while COVID-19 has been devastating to a lot of people, and of course to our in-person interventions that we've been doing. So we have quite a few for diabetes prevention and hypertension management, and these were all in-person interventions, educational interventions that we were doing. But it did give us an opportunity to, the term pivot, to do recruitment across the country now, rather than in physical locations, one physical location or just a few. But several of our studies are now recruiting across the country through Facebook and the internet, through our networks that we have, and doing all of our data collection via Zoom. And we send out a data collection kit to participants. We have, databases that we can send links to for participants to complete surveys in, and the consent form, and meeting, through Facebook. It's pretty personal. So it's actually worked out much better for us. And I think it also has given people the opportunity to learn more about technology, learn more about using Facebook. And I'd never used Facebook before COVID, and perhaps get a computer or use their smartphone to be able to reach out to people. So it's actually been a learning experience and a good one. So now we know if people can actually access the internet to participate in studies like this, which we wouldn't have known otherwise because we'd always done things in person. But it's been a learning opportunity, and good for some people across the country that we might not otherwise have reached.
Great, thank you so much, Kaimi. Well, while we have you here, we have this great question I am just dying to ask this panel. And the question is, it says, communities of color are experts of their culture. How can white identifying researchers support community-led initiatives to improve health outcomes in communities of color? What are your thoughts on that?
Well, in our studies, I mean, none of us can be an expert on all cultures. Even within your own culture, you're probably not an expert. So in our work, in our community engaged work, we always hire and train community health workers or people from the community who are passionate about working in their community and providing information and education and programs that will benefit the community. So, to me, this peer educators, community health workers, they are the cultural bridges that we need to, sort of translate, maybe not in language, but perhaps in language also, but in values and norms and concepts to the community. So to me, they are the most appropriate people to be delivering or implementing the interventions because they live the same life that the participants live. So that's how we do that. So I think anybody, any researcher of any color who uses community engaged approaches in research can do that.
Could I add on to that too, Celestina?
Yes, please.
So, just hearing that question, I think that's a really good question. And in my opinion, the best thing we could do as a researcher that doesn't identify with the population that you're working with is to listen to them, to reach out and ask people, what do you think is the issue here? Because I may not know the issues, in an urban area where the majority of people are of color. I maybe wouldn't know exactly what the problem is. So I want to hear from them, what do you think the issue is? What do you think would help fix this? Really listen to them and then build your intervention based on their ideas as opposed to an outsider's ideas of what might, work, what might help fix that. Really, really listening to me is the key.
Great, thank you. Pablo, do you have anything to add to this?
Wow, I mean, it's hard to really top what has already just been said. The only thing I can really think of is that, well, for one, my research is predominantly based on, it's epidemiological predominantly, which means it's based on large data sets that exist for various reasons already. But in work that I've done where I've had to collect new data, I think the key message here is really humility and listening, as we just heard, that was a key sort of characteristic of how I think it's what's important as a researcher in coming to a community to try to understand the health concerns and situation there. And those relationships just take time to cultivate and develop. So being able to conduct research or even further to do something about what you're finding, to intervene, requires lots of trust and respect and humility. So great. It's a great topic.
Yeah, I know. Thank you so much. I feel like we can spend the whole hour just talking about this. That's such a great question. So Kim, there is another question about the vaccine and the media and politics, changing politics, listening to different, media outlets and finding different information about the vaccine. How does that play into your work and others' work as we try to focus on the science, focus on the research to guide health policy and health practices?
Yeah, absolutely. So it has been quite a political year, as we've all seen roll out. And unfortunately, COVID-19 has become a very political topic. I mean, wearing masks, and now as the immunizations come out, it's sad to see the amount of politics in something that should be really transparent, which is taking care of ourselves and the people around us. So what do we do about this issue? I do some work in the area of vaccine hesitancy. And so looking at reasons people are hesitant about vaccines, one of which is just mistrust and a lack of education with real resources. You know, people who think that if they get their kid a measles, mumps, rubella vaccine, they're going to get autism from it, because there was one terrible study years and years ago that was actually redacted and proven to be, you know, garbage, but it got a lot of attention. So one of the things that I find is our best tool, and I try to teach this to our students as well, is just providing education with real data and strong resources that are available. And at the end of the day, people are going to make their own decision, and rightly so. But if we can help provide strong evidence as to why they should get vaccinated, not just, you know, go get vaccinated, but here's why this is going to be really important. And it's not just for you, it's for the people around you. You know, as a young, healthy adult, probably if you get COVID, probably you're, you know, going to recover and going to be okay from that. But that doesn't mean that, you know, your grandma who you may have exposed, or your, you know, newborn baby niece or something, it is. So it's really, I think, in part, helping people look beyond self, that the decision I make about being vaccinated doesn't just affect me, it affects others. You know, as herd immunity is a good example, but even just the people that in our community around us. So I think providing rationale and providing information based in science and not politics seems like the way to go. I will say one of the things I would love to see people do that they don't is to talk about the limitations of their study, right? Because we will hear some study that says, oh, this is amazing, you should do this. And we know that no study is perfect. I will tell you that I've written quite a few papers and none of them are remotely perfect. I think most of us as researchers would say, we know there are limitations to our work. So I'd love to see in these vaccine studies, have them say, here are the reasons this vaccine is great, but also here are the limitations. So I think more transparency in my mind with everyone would be quite helpful. I don't know if we'll get it or not, but to me, that would be a strong solution.
Great. Thanks so much, Kim. Well, we are coming towards the end of this Wake Up With Research. It's surprising to me how fast this all goes. We have so many more great questions, but there's a recent question that just came in that I would like us all to just spend a minute or two answering before we wrap up here for all of our panels to answer. So this question is, what is your greatest need in translating your research into community impacts? Partners, community or industry, or academia? Is it tech, policy, funding? Again, what is your greatest need in translating your research into community impact? Pablo, do you want to start with that one?
Yeah, I'd love to, thank you. All of the above. So I think this is a really important area, and in fact, it's kind of that last mile problem when it pertains to academia, because, you know, in the kind of research that we're doing on this panel, it's not enough for us to publish these high impact publications. We need to do that. That's part of our job, yes, but we also need to make sure that the work we're doing actually can potentially make a difference. And we realize science is not the only thing that drives community impact or that drives policy, but it should be, I think many of us hope it should be part of the conversation. So having that translation of science into practice or policy does require those partnerships. And ideally, in my experience, the most important thing to do is essentially bake in those partner relationships from the very beginning of the science, so that the science itself is conducted in a way that is adaptable and exactly the kind of needed scientific result that those partners really are needing and wanting. So having that relationship at the beginning and not just waiting till you're done and looking around and say who's interested in this is really a part of it. And I think also the other part of this is funding. And the funding right now is it doesn't encourage those kinds of relationships. So I think we need some new funding models that encourage the cultivation of partnerships that then can lead to kind of partnered academia and community-driven research. So I'll stop there and hopefully hear what others have to say.
Great. Thank you so much, Taimi. Yeah.
Oh, yes. I was going to say, I agree. All of those things, and including people in those sectors who care about health inequities and are innovative thinkers who can think across all those sectors and bring people together around improving health inequities.
Great. Thank you. Kim, anything to add?
Complete agreement with what has already been said. I have, maybe two pieces I would add to build on that. So one, I think some of the most research that I feel has been the most meaningful to me has been in our own community. I've received funding from national organizations and that work, has been really successful. I felt really good about that. But the pieces that I'm doing in our own backyard, to me, and being able to directly see the impact of that are really meaningful to me as a researcher. And that often means local funding, right? Because the national organizations aren't necessarily as interested in research that's happening in Spokane, Washington, as they maybe would be in Washington, DC. So I think it's those local partnerships and local funding that are just huge. I've had the pleasure of working with the Empire Health Foundation for a number of years on some projects, and we, in our community can directly see the impact of that, and I think that is just phenomenal. So community partnerships, community funding, I think is huge. Another piece that to me is becoming more and more evident is finding the right audience to share the information with. Because as a pharmacist, I attend lots of conferences with other pharmacists, and we talk about how great pharmacists are and what we're doing. And we already know that. So I don't know that going and sharing research that I've done with other pharmacists is as meaningful as it would be if I shared it with community leaders, physicians, administration and leadership at healthcare entities. So I think it's really being careful that we have limited opportunity to go share the results of our research, and we really make sure we're targeting the right audience, which is not necessarily the easy audience. Sometimes it takes some work to go find those folks, but going who really could create change as a result of what I've done. If I share this with this person, who is it that could create the most benefit, I guess, of the piloted work that I've done.
Great. Thank you so much, Kim. What a great way to end this Wake Up with Research is about disseminating to local stakeholders, our local partners, all the work that we're doing here in Spokane. We have more questions. I know we're out of time. If you want to contact me directly with a question that you didn't get answered that you really want the answer to, please do so. Just send me an email, contact me, and I'll put you in touch with the right person, whether it's one of our panelists or someone else here at WSU to answer your question. I want to thank Drs. McKeirnan, Sinclair, and Monsivais for being our panelists today and sharing their expertise and all of the work that they're doing in terms of COVID-19 with our at-risk populations here in Washington. We have another Wake Up for Research next month. It will be on March 24th at 7:30 a.m. The topic is going to look at how some of our locally based researchers have been pivotal in growing companies and impacting our economies. So we absolutely look forward to that. Again, we want to thank our sponsor, STCU. Thank you so much. We are very grateful for your support and for sponsoring this Wake Up for Research. We hope you all have a great day. We look forward to seeing you next month. Take care, everyone, and go Cougs.